The next talk is on a rather knotty problem of the management of aortic infection. Professor Wendler from King's will no doubt enlighten us on something we'd rather not accept. Olaf.
Thank you very much, Chris, for your kind introduction. So, ladies and gentlemen, thank you much for the invitation to talk about infections, aortic infections. And as you can imagine, I was asked to give a talk on this for around 10 minutes, and I was asked to cover the content of aortic root infections or aortic valve infection with root involvement, and also talk on mycotic aneurysms and in the thoracic and thoracoabdominal region. Therefore, I will only be able to give you a little bit of a taster of what can be done in these situations, but I hope I will be able to give you at least a taster, because there seems to be some variation on the transmission here. As you all know, aortic root endocarditis or aortic valve endocarditis with root involvement is something which can be quite challenging. And one of the cases I have to you to present here is a case with let's just continue. Is a case with severe aortic root endocarditis after the patient had aortic valve replacement 10 weeks before the presentation. And the aortic valve replacement, the first one in this 38-year-old woman, was done because of aortic valve endocarditis with Staph aureus. She had a 6-week course after she had a mechanical valve replacement done by another surgeon. And then she came back 10 weeks later to her GP, or actually to her cardiologist, with flu-like symptoms. At the time of the presentation, she was in heart failure. She had an echo for that reason, a severe dehiscence of the valve, and the right coronary sinus, left coronary sinus was seen. And that fine, because on the echo you nicely see the valve rocking up and down, and that was the reason why the oh, there we go. Okay, leave that. Yeah, let that run. So as you can see on the left, as you could see on the left, this is the presentation of the patient with this dehiscence, which later on was then showing in the right and left and non-coronary sinus, and this walking valve with this severe paravalve leakage. And at that time, the cardiologist, next slide please, or can I do it from here? Okay. At that time, the cardiologist gave me a phone call and transmitted the echo, and that's the reason why I blue lighted the patient into our theaters. And then we replaced the aortic root in this patient with a stentless freestyle prosthesis. Takes usually a little longer, of course, in these kind of situations, but if you address it properly, you usually get it fixed, and that's what you see on the right side. The root is restored in its continuity. There is no paravalve leakage anymore. There was no infection identified. I mean, it was there was an infection there, but all the cultures were negative. Therefore, she went on broad-spectrum antibiotics for 6 weeks. But she only was on the recovery unit for 1 day, then was discharged home after 6 weeks. And clearly, that kind of case is demonstrating that if you have even severe kind of endocarditis on the aortic root with root affection by abscesses, you can fix these kind of problems. In this case, demonstrated nicely, this patient fulfilled all the criteria of acute intervention in patients with endocarditis, and those are, as you know, risk of embolization, aortic root abscess, or heart failure. Nevertheless, the question is always, when you are in front of these aortic roots, how do you replace the aortic valve or the aortic root? And as you all know, the gold standard usually has been a homograft implantation. Stentless biopsies have been used in some centers, but you also can use mechanical or biological composites. You can restore or reconstruct the aortic root by abscess reconstruction with pericardial pressure implanting an aortic valve. Nevertheless, often it looks a little bit like here, that you have a huge abscess cavity and it all looks pretty much as a mess. And for me, it's often impossible to do the operation with a different method than implanting a homograft or a stentless valve. So what is the reason why I implant a stentless valve? Well, if you look back into a series about homograft implantation, and this year's data from the Zurich group around Marco Torina at the time, quite old data, as you can see, nearly 20 years old, but the data has not much changed. You can nicely restore rebuild the aortic root in these patients. Here 80% root abscess, 57% prostatic endocarditis, and you can achieve for in-hospital mortalities of between 5 and 10% usually. But if you look at the 5-year outcomes of these patients, you often see that the survival is pretty good in these patients. Here, 97% survival in the 5 years of the survivors of the operation. But at the same time, you have usually quite a big number of patients who come back for reoperations. And they usually do not come back for reoperations because of endocarditis, but they come back, like in this series here, 11%, because of degeneration of the aortic root or aortic homograft. Degeneration in this case usually does not mean that the homograft fails because of calcification or something, but what usually is seen is that the patients right after the first operation have a degree of aortic regurgitation. Usually that goes up to 20-25% of patients, because during the implantation it's very easy to distort the aortic root, and this kind of aortic regurgitation then leads to a failure. That's the reason why other conjugates have been tried in the past, and this again is data which is relatively old. It's from 2003 and from the Heart Center in Berlin. And what the colleagues over there looked at was their experience with homografts, what they usually were doing in patients with this kind of complex endocarditis, and they compared the outcome with the outcome of patients they operated with stentless bioprosthesis. At that time, they used a shell-high stentless bioprosthesis, which is not on the market anymore because it calcified too early. Was a pericardial valve. But nevertheless, when you looked at the 60-day mortality of these patients, there was no statistic difference between homograft and stentless. Stentless actually were lower than the homografts. And in terms of reinfection, there was also no difference, 4% in both groups, so quite low, and no difference between the two groups of patients. But what they saw was that you had much less of aortic regurgitation in the stentless group. And this is something which has been found by other groups as well. This here is not data on endocarditis, but this is data from the Roy Brompton Hospital around Magdi Yacoub, published in 2010. And what you can see is, on the red line, the failure of the homograft in terms of aortic regurgitation, in contrast to the outcome of the 10-year experience with the stentless valve at the same time. And an additional advantage of the stentless valve is also that if it fails, in contrast to the homograft, as we all know, calcifies horribly, and repeat surgery is quite challenging, whereas the stentless valve didn't do that. So that's the reason why, from my point of view, I usually use stentless valves for these kind of complex aortic root problems, and usually patients can be treated quite nicely and also particularly have, in terms of reinfection, quite good outcomes. But most important from my point of view is that at the original point of the operation, a root abscess is properly addressed, and that was maybe not the case in this patient originally. Going forward now to mycotic aortic aneurysms, a short overview on the treatment there. I mean, you all know that mycotic aortic aneurysms are quite rare, only around 1-3% of all aortic aneurysms. And in general, homografts have been the gold standard in treating these type of infections. But nowadays, you also have available coated vascular prosthesis, be it silver-coated or be it coated with antibiotics. And you have endovascular prosthetic treatment available. Homograft treatment, again, has been demonstrated in small series because no one has large series. Here, a patient group of 18 patients, mortality outcome 11% in these patients with infected thoracic graft prosthesis who were treated with homografts. And you can see 11% in-hospital mortality, but then in the first 2 years follow-up, one patient with infection died as well, and one patient had a homograft failure. But a treatment which can be offered to patients who usually present in quite a challenging condition and are difficult to address from the surgical point of view. Here the experience from Hanover comparing homografts, the gold standard with coated, silver-coated prosthesis. You can see the result is similar, 30-day mortality, 14% with 18% mortality, 2-year outcome, survival 82% with 73%. These patients usually all get 6 weeks antibiotic treatment, best of course specific antibiotic treatment according to the resistancy profile. In contrast, then, you have the data now of the early data from endovascular treatment. This year is the data from a European multi-center study which analyzed retrospectively data on endovascular treatment. As you can see, ascending aorta, only 3% of patients, descending aorta, 28% of patients, but the smaller group compared to the abdominal intervention. In 5% of patients, there was conversion to open surgery needed. The duration of antibiotic treatment in all these patients was 30 weeks, so it was quite much longer than you usually would give if you use, for example, homografts. And the rate of infection-related death was 19%. 77% of these infections appeared after the discontinuation of antibiotics. And therefore, one needs to be careful to just jump on the endovascular treatment. It is a less invasive procedure, but in terms of how radical it really eliminates the infection, it's quite questionable. I mean, the 30-day mortality here was 9%, 1-year mortality 25%, 5-year mortality 45%. If you compare that with some of the other data, it is not automatically the right thing to go forward with. There are additional protection methods to stabilize the outcome. You can wrap the implanted graft with omentum. Latissimus dorsi, intercostal muscle has been used. I believe that's a little bit to preference of the surgeon. I usually use omentum. Lifelong antibiotic treatment is something some people use. In general, it's a difficult group of patients to deal with. Therefore, I would like to conclude the main goal in patients with aortic infection is the elimination of the aortic infection and its focus. That is something which is a little bit questionable with the endovascular treatment. In patients with aortic valve endocarditis and root abscess, stented root replacement offers an elegant alternative to homografts. It is always available. You never need to wait for the right size to come into your hospital. You always have it there. And to finish the talk in terms of treatment of mycotic aortic aneurysms, TAVI offers a less invasive kind of treatment option, but homografts seem, from my point of view, still be the gold standard as they may treat the infection best in these patients. Thank you much for your attention, and sorry for the problems with the slides.
Thanks very much, Olaf. What do you think about extra anatomic bypasses and the place for that? Because that's what the vascular surgeons get very keen on.
Yeah, it is something which has been done, has always been done. I mean, from a vascular surgical point of view, I would say I only have thought about extra anatomical bypass in patients who I found not fit enough for a radical approach in terms of addressing the infection. If I would have that in mind, I would say. So it's not ideal because you do not eliminate the infectious focus. If you don't eliminate the infectious focus, you have a problem in the long term. But you avoid a large trauma surgery, and maybe you have your patient longer surviving the less invasive approach. But that in mind, I would say, then maybe I would more prefer to go into the endovascular treatment type of direction. And what I would say is, take an approach which is as less traumatic as possible, get control of the infection, build the patients up, because as you all know, a lot of these patients, particularly if they have abdominal aortic problems, they are often not only they are often affected by the long-standing infection, and they are often therefore not in good condition. So put in a prosthesis, treat them with antibiotics, build them up physically, and then they may be ready for an operation where you really eliminate the whole infectious focus. But it is, I mean, as you know, there is no gold standard for this kind of treatment. It is a challenging type of patient group, but if ever possible, I would say be radical in getting the infection material out.
I mean, I think if you're going to use extra anatomic, you've really got to stent it, because otherwise at some stage it will just rupture and go.
But the question is, if you have to stent it anyhow, why not just stent it get the specific antibiotic treatment started, build the patient up, and then go for a radical solution. But I mean, the patients need very individualized type of treatment. There is no question about that.
No questions. Shout.
Can you comment on the timing of surgery with regards to pre-op antibiotics? Do you wait for a period, or if you already made the decision you are going to offer it?
You mean for, I would say there's a difference between aortic endocarditis, root endocarditis, and then maybe you focus more on the root endocarditis from that point of view. I think there are some patients who press you to go forward, like this lady with the walking valve. I mean, that valve was, half of the circumference was off the aortic annulus, so I think these patients you cannot let wait. In general, I would say if there's a high risk for embolization, cerebral embolization, or a high risk for acute failure, I would not necessarily wait for the outcome of microbiological cultures. If you can wait, I think from my point of view, it would be helpful to have the outcome of the cultures. Take cultures, start empiric antibiotics. After 48 hours, you have a better situation in terms of the infectious status, and you also have the result from the microbiology, and then do the operation. But if you have a big vegetation there which is at risk of flowing off, I think it's better to go in early and avoid the stroke than waiting, having good antibiotic profile, but having a stroke patient there. That's my personal preference.
I think from my point of view, one of the commonest things is not mycotic aneurysms, it's infected grafts.
Yes.
And often those patients are the ones who've got a big thoraco and they're 75, and will you redo it? Can you put a whole part? No way.
And that's the reason why I answered that for aortic roots. With the grafts, I think you have more time to think about things usually. But as Chris said, the patients are usually in a worse condition, I would say.
Jeff.
I'm a great fan of homografts because I think they're very versatile, particularly with access to this construction of microbiome and things like that. You do a lot of them. But people have been put off them because of the future degeneration and having to sort of get rid of them. With your experience with TAVI, have you had the experience of actually TAVIing a homograph? To me that makes sense, and it may sort of increase my enthusiasm for homographs even more.
Yeah, there is experience with TAVI and homografts. I mean, by the way, I share your disappointment about homografts, although I used a lot of them in the past. That's the reason why I use a stentless valve. But coming back to the TAVI, there is experience in doing it in homografts. But the problem is, you can do it in homografts if they are fully calcified, because then you have enough resistance to put a TAVI in. But the problem why these valves fail so early, and that is something which is the regurgitation rate, grade 2 regurgitation after a homograft replacement in the condition of endocarditis is around 25%, even in experienced homograft centers. And the reason is that you have distortion of the graft. And the problem is that early failure means that you do not have a calcified homograft. So if you do not have a calcified homograft, you have nothing to fix the TAVI in. So a lot of these patients will not be feasible to treat with a TAVI prosthesis because the homograft fails in a different way. The patient has aortic regurgitation, and as we all know, if you have aortic regurgitation because of a root problem, that gets worse over time. And they fail at a time when you do not have the structure there to put in a TAVI. So TAVI is not automatically the good alternative. And that's the reason why I personally find the stent is much more comfortable from that point of view. You always have it on the shelf. You can do the operation when you want. You have it in all sizes. In terms of reinfection, there's no higher risk. If you have a problem with the endoterminal leaflet, you just implant the stentless into the left ventricular outflow tract without any problem. You always can implant in a way that your abscess is outside the prosthesis afterwards, same like with the homografts. And sometimes you need to do, and that was the reason why there was a prosthetic prosthesis in the way in this lady who I put it there. Sometimes you need to if you use the freestyle, for example, which I use, then you sometimes need to elongate a little bit with a prosthetic graft in addition. But that's least of the problem in that context.
I don't know. We seem to be seeing more infection of the conduit, root conduit, or the kind of the descending or thoracoabdominal kind of graft, or even stent graft. And then sometime 2-3 years after the implantation or 2-3 years after surgery. Is it because we're doing more of those procedures and we start to see more infections, or whether are we not treating them like a prosthetic valve properly, like a kind of surgical graft and stent graft? So when they have any procedures or dental procedure, there's no antibiotic cover. I don't know what's the answer to it, but I
don't know.
I do seem to kind of notice. At the moment, I've got about 3 or 4 patients waiting in different hospitals coming across for.
I don't know really. I mean, I published 2 years ago in the British Medical Journal an experience with a few patients who had different kind of issues. They had one had a VSD and the other one had an ASD, and there was one with a prosthetic valve. And they had been fine and stable over a period of 15-20 years, no problem at all. I mean, from my point of view, they should have had surgery earlier, but they were not under my care, but they were fine. And they had always their dental antibiotic prophylaxis. And then that was stopped, and 2 years later, one had half a year later, 1 year later, 2 years later, they get infection on their cardiac problem. I don't know. I mean, to me, it sounds absolutely silly to not offer antibiotic prophylaxis to these kind of patients, but I don't know if that explains some of that.
Do you see the same in the U.S., John?
No, we don't, but most of us still give the antibiotic prophylaxis. But there was a beautiful presentation from the UK at the American Heart Association meeting where they showed that the curve of infections just went up.
I'm not
that
surprised.
the exact month that the routine antibiotic prophylaxis was stopped in the UK.
I'm not so surprised. I'm not surprised to hear that. I mean, I have to be honest. I mean, I always dictate under my letters for patients that they should have endocarditis prophylaxis for future treatment. And I mean, if one wants to try how lack of endocarditis prophylaxis works in patients, one should maybe start with the ones who have native valve disease, because that's not such a big thing to operate. But if you include also the ones with prosthetic valve, that is, I think it's silly, but I think it is as it is.
Olaf, thank you very much.
Thank you.
In view of the time, we're going to close the session.